My name is Jeanette Abbott. I'm the Manager of Quality Improvement and the Privacy and Access Officer for the Heartland Health Region. And it really was my pleasure, even though the weather was so not nice, to be here for the past 4 weeks. We are RPIW 53, and we will be speaking to a Tac Time of 20 minutes. This is our team picture. We are team boarding pass. We figured that you can't get on a plane without a proper boarding pass. You shouldn't be able to get into surgery without a properly completed pre-op. Here's our project form. Our project is to eliminate defects in the patient pre-op package that create delays in the OR start time. The process flow we looked at was from patient start time to when they get to OR holding. And the situation was that we do have patients showing up for their surgeries and the pre-ops are not complete in many, many cases. So then the nurse is having to spend time doing that work. Our theme is that all patients arrive at day surgery with required information and ready to go on time. Here's our value stream map. The initial timed observations left us with a lead time of 43 minutes 30 seconds to perform the work of getting the patient ready, assessed for surgery. We had 59% value added. So there was a lot of work that we could do. Our fishbone. The initial fishbone, we had a lot of contributing factors, but as we looked at them, we realized that many of them, while were contributing factors, were really not part of the focus of our RPIW. So ultimately, the fishbone slide is we had 19 contributing factors that we worked with. Some to do with patients not knowing, some to do with patients showing up actually without even a pre-op because they either didn't realize they had work to do or whatever. Okay, so the next, the target progress report. We looked at walking distance, and it started out with, we looked at the nurses in day surgery, how much walking they had to do once the patient got into day surgery. It turned out they were walking about 330 feet. Our goal was to get that down to 165 feet. We also had our productivity. We looked at the number of patients. Initially, what was happening was we had 4 patients showing up for first thing in the morning. We had actually 3 RNs managing 2 patients. That was our gain, or that was our ability to get those patients to OR holding by 7:30. Our goal was to get those 4 patients to OR holding by 7:30. And the capacity, we had a capacity of 1.8, and that was the capacity of the nurse to process the patient. We wanted to get that up to 2.7. Our Tac Time, we focused on the first 4 patients of the day. So we were only looking at a 45-minute time frame. So we ended up, for those first 4 patients, a Tac time of 11 minutes 15 seconds. So to keep us in flow, we had to have a person moving through the system every 11 minutes and 15 seconds. When we looked at our PQA data, we looked at data that was collected from OR scheduling. And we looked at packages with missing documents. So for the period August 26th to September 20th, 23 of the 38 packages we looked at had missing documents. 18 of them had 1 missing document. Two of them had the whole package missing. 2 of them had 2 missing documents, and 3 had 1 missing document. So when those patients show up, the nurse is scrambling to try and get that information to get it in the chart so that the patient is ready for surgery. We looked at the defects according to specialty, and we also looked at checklist errors because there's a checklist that goes along with it, and we looked at incomplete. There were 13 incomplete, some still using an old form, some there was no checklist provided, so that in OR scheduling they didn't know what was supposed to be in the package, so they didn't know if the package was complete. And then sometimes it was checked off that it was ordered, but receive the check. This is our time observation form. And we did 3 days of data collection. And it just shows that some of our times that we had from 3 minutes and 38 seconds right up to 49 minutes, 48 seconds for this OR assessment. Our 5S, we 5S the charting desk in the department. It was tough to find a 5S to do actually, but you guys are so good. Actually, when you look at the picture, we had charting forms that were on the desk in the bottom left-hand corner that really needed to be in another area a few feet away. It was cluttered, there were signs there were just things that needed to be moved out of there. And then if we look to and this is just immediately to the left, about 4 to 6 feet, wasted space up there in the top left. So that's what we looked at for moving those forms that the unit clerk needed. And this is just another view, again, showing that wasted space. So we contacted our maintenance guy, and he was very, very nice and came and fixed that for us. Our evaluation at the beginning, our score was 1.7, and when we were done our 5S, we were at 2.9. So now we have to keep it at 2.9. And here is our post-Kaizen. You can see that the space is cleaned up and available then for anybody to sit down and do their work. This is showing the top left where the shelf was put, so now those papers have been moved off of the charting desk and into that area. Our spaghetti diagram, this shows that the 220 steps or the 330 feet that the nurse was walking back and forth to the fax machine, back and forth to the patient bedside. And then we had our standard work combination sheet. You can see that our tac time there at 11:15, we were going way over that for tac time. Our percent load chart, what we learned for the first 2 days that we were doing the data collection, 50% of our patients were actually getting to OR holding within by 7:30.
Hi, I'm Amy Hollins, and I'm the manager at one of the surgeon's offices in Prince Albert. So we started looking at the incomplete pre-op packages, and from the things we're able to observe, there's a couple things missing. A lot of them were missing documents that were required, and another thing, sometimes just information was incorrect if the patient had revealed something, and we wanted to be able to catch those earlier in the process, so we needed to assemble a complete pre-op package. So we started with this document. It was prepared by an RPIW number 27, which is a couple years back. It's a very good document. It was made up by surgeon, nurse, anesthetist, possibly some others, and we wanted to start with the information they had collected. So from the form, we moved this one piece off of this form, and Claudia will share what we did with it. And then at the bottom of the form, there was some more information that we've incorporated into the whole form. So we didn't lose any information, and we were able to go forward with the information. So the next shows the new pre-op assessment checklist that we have developed. We've cleaned it up, it's straightforward. There's a couple things that we've added. Near the top there, we've added the pre-op assessment checklist is required for a pre-op package. So basically every pre-op coming in will have this follow the patient from the surgeons, from the family doctor, all the way to scheduling. All the check marks will match the documents that are in the package. And there should be no confusion over does this patient need this or does it not need this, because the guidelines are there. And the second thing is we've got room for the surgeon to add what they have required, which may be over and above the regular requirements. So nothing is missed. It's very clear at each point of check what is required. What we're going to do with this form, we're going to get it published in the two EMR programs that are used the most in our area, which is Acuro and MedAccess. And that way we can roll out the form and tell people it's ready. Just go on your EMR and download it. It'll be ready with clickable checkboxes and text sites so that it's ready to use. So the next idea sheet here, we need to inform and engage the GPs in the process. So part of that is making it easily used, so we're going to publish it, they can get it. But the second part of that is the letter. This is a draft of a letter that we've put together that the SMOs are considering, and they will be sending it out to the doctors, the NPs in our area and in our surrounding areas, because we get a lot of out of the area patients, and it's going to be sent with the letter saying when it's going to be standard work by November 1st, I think we were suggesting. And so that letter is going to go along. Everyone will be informed of the new process. And this last piece is a protocol that was also developed in RPIW 27. And this piece, we've just done some edits to bring it up to the current information that we've been working with, so that everything is in agreement. They won't have something that contradicts another piece of paper. So that's what we've done with that.
Hi. Good afternoon. I'm Claudia Driscoll. I'm a patient family representative. In the period of time that we spent together as a team, there were some observations that we made that needed to be addressed. And one was the role of the volunteer at the desk as it enters into day surgery. What was happening was, following the patient going to the admitting office, they received a package of information that they gave to the volunteer to store on the volunteer desk. So what has been changed in this week is that that package will stay in the hands of the patient. The volunteer will take the patient to the day surgery center and give it to the nursing staff direct. The second area that we looked at was, as you just saw in the pre-assessment admission information, the letter by the doc from the medical officers, and a change to the checklist has been a change to a teaching tool for the family physician to review medications. I, as a patient, family, we are told, take this pill, but we don't know sometimes why, how frequent. And so that addition, that piece of paper, or that guideline, that checklist will be added to for the family physicians. The other revision that we didn't get to was the information pamphlet that is given to the patients prior to surgery, that they can take home, review by themselves and with their families. That's yet to be done. Now, throughout this week, I put myself in the shoe of a patient. And I was thinking, yes, I went to the doctor tells me I need surgery. I'm referred to the specialist. I go to the specialist, I'm told I'm going to have an operation, and someone will phone me as to the time and date. I should not be going to surgery until everything is collected. All the information that is collected by the medical doctor and the surgeon goes to the OR scheduling team. Stop the line. They have a checklist to be sure that all documents are present. If not, stop the line. And to keep uppermost, as we did and noticed everybody does, patient thinking first. Thank you.
Hi, good afternoon. I'm Eunice Cutting. I work as a staff nurse on the day surgery unit. I'm very honored to represent our unit in presenting new work standards to enhance our patients' readiness and journey through the system. Our patients come first. Our goal as a unit is to have a seamless, stress-reduced day surgery admitting process for our patients and their families, and allow them to proceed on time for their surgery, thus meeting our goal. To meet our goal, organized and developed a work standard. The work standard provides a clear role for our nurses on the unit to play. For our first work standard, we addressed having the chart prepared with all the documents necessary to send our first cases to the operating room. Prior to 1500 hours, we have asked that one nurse review the first 4 charts. We are reviewing for any missing documents, any missing labs, any missing tests. Why we have chosen 1500 hours as our time, it allows us then the opportunity to address our missing documents. It allows us to search for them. It allows us time to phone the lab, to contact surgeon's office, GP's office, etc. It's totally stated out on what we need to do. It then allows us to prepare requisitions for the missing tests and put them on the front of the chart, thus eliminating extra work the morning of surgery. And we also have a method of communicating with a sticky note showing our deficiencies, so when I, as a different nurse, come to pick up that chart, I know exactly where I'm at when I start that admission. Our second process was the day of surgery. To expedite and allow extra time for that admission, a work standard was developed outlining the roles of the different nurses in the unit. We have one nurse setting up our computer system, getting our unit set up and ready to go. We have nurse 2 and nurse 3 opening the door early and bringing in only those 2 pre-assigned patient admissions to allow the extra time. And again, the admission process is based on prior review. This will provide us 15 extra minutes to prepare our patients for the OR. Thank you.
Hi, my name is Nicole and I work in OR scheduling. So one of the things we did was develop a new pre-op envelope. The old pre-op envelope had a checklist that was not being used as is, and only 3 surgeons' offices were correctly using the pre-op envelope checklist. Even though they were using it, it didn't reflect all of the documents needed to proceed with the surgery safely. We have developed a new pre-op envelope which includes only the information that OR scheduling and day surgery needs. Another thing we did, we developed a work standard using the preoperative checklist to make sure OR scheduling is receiving pre-op packages 2 days prior to the surgery date. OR scheduling will receive a complete pre-op to bring to day surgery so the patient's surgery will go ahead safely. The day before surgery, by 12 o'clock, the OR scheduling office will select 2 patients to come in at 6:15 to get registered through a meeting. The OR scheduling office will provide 2 patients' names to day surgery so the nurses know which patients to expect. OR scheduling will be using a criteria to select those 2 patients. The day before surgery, patients call the OR scheduling office between 1 and 3 to confirm their arrival time for surgery the next day. By 3 o'clock, if the patients who would normally call to confirm did not call our office, we will then contact the surgeon's office to let them know which patients have not called to confirm. It is then the surgeon's office responsibility to follow up with the patients as available. And here is our multi-training schedule that we will use to ensure all staff are trained to the new standard work.
Good afternoon, I'm Michelle Grip-Suter. I'm a registered nurse and co-lead on this workshop along with Jeanette. I thank you all for being here in support of our patients. The first thing I want to show you is that with improvements that were implemented, we were able to fill it a much leaner fish, I guess, and we took out 15 contributing factors for a reduction of 79%. On our spaghetti diagram, when we looked at the nurse assessing the OR chart to the final step of having all the required documents on the chart, we were able to eliminate 255 feet, and that was just looking at one nurse for one patient. So if you only look at the first 4 patients of the day, that's over 1,000 feet that we saved. Freeing up time for the nurses to spend with the patients. Our time observation form, we were lucky after mine and Jeanette's time there, they let us back in to observe some more. And we really were looking at the timings for the staff going through the file and what kind of time it took to correct the defects or missing documents that were not there, or to correct the ones that may have been incomplete, or the PSAQs that were not done. Something else that was really important for this RPIW was to know that folks were getting there on time, the first 4 patients, to our OR holding by 7:30. So those are our marks on the side there, what time the chart was up and ready and what time they actually went. Our new value stream map looks a little leaner as well. We were able to achieve a lead time of 10 minutes and 20 seconds, which was a good decrease. So now our value added time is actually 100%, and there was no value added times. We were able to take out the weights. We addressed 10 of the starter bursts that came out of this value stream map and this process. And there are a few remaining areas. And Claudia talked a little bit about sometimes patients come with a poor understanding or decreased knowledge of their medications, which causes delays. And we're going to put forward through to the sponsor and process owner the idea about improving the patient booklet that they receive prior to surgery, because there's a lot of things that could be on there regarding medications that are actually missing. Something else we'd like to address, as Claudia mentioned, we don't have a stop the line for OR bookings that go ahead and proceed without all the information being available. One thing we noted, information from the staff, was that patients arrive at day surgery and there are no pre-op packages. Sometimes that's a result of a urgent or emergent surgery, or folks that are filling in at the last minute because there was a cancellation. We still want to make use of that OR time. So I don't know if there's a formal process for getting those folks ready, but surely with the time that we're freeing up, we're going to be able to use some of that time to help ensure that those folks proceed with their surgery safely as well, with all information in place. Our standard combination worksheet, we were able to remove some steps and also to achieve under our Tac Time. Percent load bar chart looks better after as well, with only one surgery that we observed starting later than, or sorry, not the surgery starting later, but 2-hour OR holding later than the 45 minutes that we set as our target. Some results on our progress sheet to note is that our walking distance for the nurses, we decreased it by 77%. Our lead time decreased by 76%. Our quality, so number of defects, is there were 50% fewer patients not in the OR holding by 7:30. So more people there on time. Our productivity gain increased by 44% with the changes, and our cycle time also was reduced by 59%. We were able to check off quite a few things on our newspaper. A few things that are remaining are, as I mentioned, the stop the line, but we're hoping with the new process that some of that isn't going to be necessary because everything will be in place. Another thing we talked about was the nurses in day surgery having eHealth viewer so that they could access labs if labs not available, labs not around, which is something that we experienced, that they would be able to still look at lab results and get them on the chart. We also wanted to talk to Young Lai in medical imaging to see if there was anything that could be done about performing ECGs prior to 8 a.m. in the morning, because if we have to have someone in the OR holding by 7:30, it doesn't work for them to arrive at 8. Something really exciting is adding the pre-op checklist, which was newly created to the EMR, and we have Amy Hollins, and we put out a question to someone else if they would be able to do part of that process too, and getting them into Curo and into Med Access. Our workshop summary, Well, you know we developed some standard work, and you know that we have a letter to the physicians and a new pre-op checklist for them to use. We realize that some of the standard work are still Band-Aids, and we really hope to tear off those Band-Aids once the root cause is eliminated. And I think with the pre-op assessment checklist, that's really going to be something that we can all achieve. The lessons that we learned from the process, from the information gathered and from each other, is that you can't get to the root of the cause if you don't ask the 5 whys. Communication amongst everyone involved is very important for understanding and engagement. The culture of our workplace is a very powerful influencer of engagement. Involving staff in the decisions that guide the process results in better outcomes for the patients. Small ideas can become a big change, and care must always be patient and family first. A big thanks to our team. Very proud of everybody for all the hard work that they did. They really gave every effort every day, and were very interested in making improvements for the patient. I want to thank my co-lead, because without Jeanette, I would still be on the first Valley Street map trying to figure out how to format it on the computer program. So if you ever get a chance to do one with her, I would really suggest it. I want to thank the people in the departments that invited us in to observe what they do every day for the patients, and who answered all our questions, because we had a lot of them. And I really want to especially thank Claudia. Thank you, Claudia. She really asked great questions and always kept us focused when we said, what if we try this? What if we try this? She'd have more questions to ask, and we'd be like, oh yeah, like, okay, from the patient's perspective. And she really kept all of our thoughts and our focused on towards the patient, and how in the end does this help the patient, and was really valuable for our team. So thank you very much.
Everybody else.